Good morning. I'm going to give a talk about the anterior surgical exposure to the cervicothoracic junction. You have to understand that I'm going to talk about these exposures. We are going to talk not for the low cervical because it's well known, but for the supraclavicular and the transclavicular, transmanubrial, and transthoracic. We need to know some things because we are going to this area. And you know, this area is quite deep because it's the anterior part of the cervicothoracic junction has deepness, and it increases from cranial to caudal. Also, we have the sternum in front, and sometimes we have the upper border projects in different levels, from C7 to T3. And we have the main vessels, big vessels. Sometimes we need to ligate them. So we can go to the anterior approach, or we can retract them. And we have to have in mind that there is the thoracic inlet that slopes forward and downward, and it's oblique. As you can see, and this is quite oblique. So we have a space that's narrow. Anterior posterior is 5 centimeters, and the transversal is 10 centimeters. We have the manubrium in front and T1 in posteriorly. And in this narrow place, we have, you see the big vessels. We have the trachea, the esophagus, the lungs, and we have to go to the spine. Here is slight reminder of the anatomy of the muscles. We have the sternocleidomastoid muscle, the thyroid. We have the omoioid, inferior and superior, and also the scalene muscles. Here are the veins. We are encountering the veins. We have the superior vena cava, and then we have the left brachiocephalic vein that goes behind the manubrium and the clavicle. And also we have the aortic arch and the left subclavian, the left common artery, and the brachiocephalic artery. And also we have to remember that we have also the thoracic duct here. So for the various branches we have, we have the recurrent, laryngeals. We have to remember that the right passes under the subclavian and the left passes around the aortic arch. They both go to the tracheoesophageal groove, but it happens higher on the right. So we begin with a supraclavicular approach. We use it usually for biopsy, but we have full access to T1, T2, and there is potential injury to recurrent laryngeal nerves, the great vessels, brachial plexus, and dura. So we put the patient supine. We usually slightly hyperextend the neck, and we rotate the head away from the side of the approach. If we go from the left, C6 to T2, we have the thoracic duct. If we go from the right, we have to identify the laryngeal nerve. And we usually, it's better to go from the right supraclavicular approach, so we avoid thoracic duct. So our dissection, we dissect through the sternocleidomastoid muscle, and usually we put a finger under the sternocleidomastoid muscle to protect the venous structures, and take a look for the internal jugular vein. After we take out the muscles, we see here we have the veins and the arteries, and we have to retract, we have to identify the phrenic nerve, and also we need to retract the jugular vein, the phrenic nerve, and the carotid, usually to go to the spine. So you remember, we have to protect the vein structures in the other surface of the sternocleidomastoid muscle. We have to protect the jugular vein medially. We have to identify the phrenic nerve and then retract the vein, the phrenic nerve and calcium medially to go to the spine. For the transclavicular transmanubrial approach, we position the patient supine. We also slight extend the neck, and we rotate the head to the right. We can use this with different incisions, and also we can combine it with a low cervical approach. So we can use this incision to the sternocleidomastoid muscle, or we can do it like a we can do it like an angle, or we can do it like this. So here we have the structures we have is the sternoclavicular heads of the sternocleidomastoid muscle, sternoioid and sternoidoid muscles. We have also to expose the medial third of the clavicle and the manubrium periosteum. We can take out the sternoclavicular heads and the sternoioid muscles and retract them laterally the heads of the sternocleidomastoid and medially of the other muscles. And then we blunt dissect the viscerocarotid plane. We can divide the head of we divide the clavicle in the medial third, and we disarticulate the head from the sternoclavicular joint. We have to protect the brachiocephalic vein that's under the clavicle. Sometimes we can take it out with the muscles. We can take out the manubrium and the clavicle along with the head, as you can see. We can take this, the manubrium out. And here's what we have. We have here the vein, and so we have there the spine, and we need to retract the carotid sleeve laterally, the visceral structure medially, and we retract the great vessels caudally. So we do the exposure from the left side. We protect the brachiocephalic vein. And we need to identify the recurrent ventricular nerve. We can retract the great vessels caudally, and also with visceral structures medially and carotid laterally. When we go for the transthoracic approach, we have the same position. The difference we can combine the low cervical. The difference is that we split the sternum. We can have a very good exposure down to the T4, and you have to remember that we retract this is laterally, the visceral structure medially into the great vessels caudally. Thank you. Thank you very much for your attention. Any questions?
Thank you, Ioannis. Very comprehensive.
So this will be a relatively short talk because I'm only going to talk about one approach, a posterolateral approach, which is this sort of gets into that realm of being between this course and the skull-based course. So it's something that you at least have to have some concept of what to do, and I'll use the time that I save here to add on to maybe my talk a little bit later on. This is a nice summary slide out of the Spencer Sontag and Bambakitis book about approaches to the foramen magnum. And you can see from this that you can approach the entire foramen magnum through a variety of approaches. many of which we've already talked about here. And so things that you will be able to do. So the indications for a transcondylar approach are lesions that are on the inferior portion of the clivus and anterolateral brainstem. A variety of pathologies that you can address this way, including neoplastic and vascular lesions. You can also approach intramedullary and extramedullary lesions of the spine. So the patient positioning, I'm just not gonna read the words. We're just gonna talk about it a little bit, and that's one of the important parts. The idea is to try to put this suboccipital region at the highest point in your exposure, so at the apex of it. So that means that you have to turn the head about 45 degrees for the contralateral arm, so that gets the mastoid facing up, and then you have to laterally, as you can see, laterally flex the neck to the ipsilateral side. Once again, just in an attempt to bring up this this portion of the bone so that you can work, basically looking parallel to the petrous ridge when you get there, and then suspending the arm somehow to keep it out of the way. And this can generally be done with a sling wrapped around your Mayfield head holder. This is typically how I would approach it. So the other thing too is this upper shoulder tends to get in the way. So putting some tape on it and retracting it caudally down is a relatively good idea. People talk about risk of injury to brachial plexus doing this. I think that's a relatively rare problem doing this. You could. I hate doing things in the sitting position because it's an uncomfortable arm position for me. It's uncomfortable. As I get older, I have sort of a fixed kyphosis of my thoracic spine, so it's a difficult exposure and comfort level for me. Yeah, it's age. It's age, and I readily admit that it's age. Elderly. So the incision for this needs to take into account that you may need to do an occipital cervical fusion with this, particularly if you remove more of the occipital condyle. So the incision typically begins at the mastoid process, is carried up laterally, and then it gets to somewhere around the superior nuchal line, and then down the midline to expose what I would say is both sides of the spine. Some people have talked about unilateral fusion. I think that's a relatively bad idea in my own hands. I'd rather fuse on both sides rather than a single side. The same thing with unilateral fixation with the T-lift. It's not just something that I think is reasonable. You may get away with it on occasion, but it shouldn't become a practice pattern. All right, and then we go and expose the suboccipital region. All right, so bone taken, muscle taken off bone. Leave about 1 centimeter of muscle so that you have something to close to later on. Expose the suboccipital region, the arch of C1 and C2, and then we work on identifying the vertebral artery, which is a necessary skill for this. So you need to be able to find the vertebral artery laterally, both in the transverse foramen of C2 and C1. Depending upon what you're doing, you may need to mobilize it to get it out of the way, and you should identify the point that the artery pierces the dura. Once again, one of my skull-based partners always says it's always better to see the artery to avoid injuring it rather than finding it by mistake. So be careful, find it up front, and then it all depends what you're trying to do, and that leads to whatever dural opening you will need to get your exposure. In addition to going both cranially and caudally, and then doing your work, and then doing your fusion if you need to. Remember that you should try to preserve more than half the occipital condyle, otherwise you'll end up with instability. And also remember that the hypoglossal nerve sits in the anterior third of the occipital condyle. So you want to avoid certainly going into that area and avoiding injury to the hypoglossal nerve. So pretty simple approach. I think it'll be something we'll talk about and do in lab today. It's kind of a neat exposure, gets you a lot of anatomy. So there's really not a lot to this lecture, which gets us some time back, which I may take later.
Good work, Greg.
All right. Thanks.
Professor Yokotel. This next talk on cervical posterior foramen.
thank you for giving me some more time.
That's because I took it away from you the last time.
That's okay. So, this is now a very different topic, and we talk about foraminotomy. And since I have not done this microsurgically, I will show you only endoscopic images, which I think is no problem because the technique is absolutely the same. So we talk about the approach to the posterior neuroforamen for decompression of the nerve root. And this is a very old procedure, has been described many times, and it's a very easy procedure. I think if you have a good bone effusion and just radicular symptoms on one side or both sides, and a degenerative spine, I think it's worth to consider this foraminotomy for decompression of nerves. So we rather do this in such a condition. You can also do this with the disc prolapse. I don't know if the results are as good. This is a matter of discussion. I personally prefer rather the anterior approach if you have a disc prolapse, because there's no way when you do a posterior foraminotomy, you have at least to harvest a little bit, maybe 1/4 of the facet. So then you take out the disc and you sacrifice part of the facet, and you have so terrific results with the anterior cervical ACDF. I think, well, in our hands, we rather prefer the ACDF. So what are the advantages? You don't have any exposure of the anterior structures. You have a much better exposure of the nerve. I think it's just wonderful to see the nerve from posterior, much easier than from anterior. And of course, you have better access to any structure in the neuroforamen, particularly if they are posterior to the nerve. What are the disadvantages? Well, anything which is anterior to the nerve is difficult to decompress. Also, you have to deal with a congested vein, so you have really some risk of venous bleeding, which is sometimes, well, quite difficult. So we did a couple of these procedures in the semi-sitting position, actually, which I think is very nice. The disadvantage is that it might occur that you have a venous air embolism, and it's more difficult to treat this and to notice this than in a traditional semi-sitting position, because in the cervical, just the pressure on the jugular veins will not show you the open vein in many cases. So you have to have some more experience. If you don't have experience with the semi-sitting, or you let unexperienced people do it, I think rather a flat position is preferable. You have some neck pain, particularly in the larger posterior approaches. I think pain is an issue. While in the anterior cervical, pain is no issue. I think they have some swelling problem for a week, and that's it. Posterior approach, pain is an issue. So I think this, if you do this posteriorly, I think at least you should use a tube system, so to have a minimum muscle trauma. Well, as I said, you have to deal with the facet joint to some degree, and it's always said that there's a risk of spinal instability. Well, a significant instability just doing one level, one side nerve decompression with a posterior foraminotomy, I think, is not an issue. I've never seen that. So there's some papers out there. What is the reason for minimally invasive technique? I think I just go over this because it's not in the focus here. But there's basically not really any data which favor the minimally invasive or procedure over the other, except for post-op pain and in hospital stay. So here, this is the conclusion of the second meta-analysis. Both can be treated with the cervical radiculopathy, can be treated with both methods, so open and minimally invasive. There's no significant difference between those two groups. But there are some advantages, particularly if you really do this small down. You have a high do this with a small approach. You have a high magnification with an endoscope, and you have a beautiful visualization. You can reduce the approach, the trauma of the approach, and if you have this, ideally with an endoscope, you have a completely new technique. This is only the case in the endoscopic third ventriculostomy. I don't know any real endoscopic procedure in the spine you cannot achieve with an open approach. Well, we have to have in mind that we can treat all this with an endoscope, but we need sufficient decompression. So I think one of the big advantages is that you have a very high magnification and better illumination. This is an example for pituitary surgery, but this is the same we have in the posterior cervical, right? You have a microscope and a lot of lights, but basically at the bottom of the surgical field, only a small fraction of all your image of all your light is seen. So with an endoscope, although the resolution is much less, you have a much better exposure, much better illumination of the area. And this turns out, we did a study with 10 neurosurgeons, surgical residents in 10 patients, and it turns out that using the endoscope, they recognize significantly more structures in the spine than with the same tube and the microscope. So it's the endoscope, the magnification and the good contrast with the high definition technique gives you better results. Okay, back now to endoscopic cervical anatomy. There are just two papers on this. I don't want to focus on this. Now we go for the surgical technique. I think it's again very important is positioning, and if you don't know exactly which level you're gonna, or you cannot expose the level you want to do surgery on, this is a difficult thing. So for example, frequently see 6, 7, 7, 1, and you don't see exactly, you have no exposure of the level at the X-ray. That's difficult. Particularly if you have bony stenosis, you never really are sure that this is the right level. So what we do this, then CAT scan navigated. It's a big advantage. If you don't have X-ray control, it's very difficult to really judge a diseased segment from a non-symptomatic segment, because all patients have bony stenosis in all levels. Okay, so this is very important, and this might lead to semi-sitting positions in some patients, because you really, I think you should try to get a lateral X-ray for verification of the right level. You could do AP as well, but AP is not that easy if you really want to exactly expose the level. It's a little bit different. If you don't have a straight approach, this is a matter of discussion. Particularly the smaller approach you use a tube system, and you have angulation of the system. It's very difficult because exposure of the nerve root. You think you're right on top of the nerve root, but sometimes you're more cranial, more caudal. And in AP, this will look like almost at the wrong level. AP is even more difficult than lateral. You play with the angles, yeah, I agree with you. It's possible, but there's so many mistakes done, and AP is more difficult to interpret than lateral. I mean, would you agree with that? I think AP correct positioning is more difficult than lateral, particularly if you have 6, 7, 7, 1. It's not that easy. Okay, so this is now the positioning. I really strongly recommend to do a straight down approach. If you don't go straight down, if you have an articulation here already you will approach the nerve. It will not be right at the level of the facade. It will be a little bit cranial, a little bit caudal, and you think that you decompressed everything, and at the end, actually, there's only the upper 1/3 of the canal you decompress. So it's, I think, important to have a straight approach down. And then it's important to really start, I think, from medial to lateral. Start lateral. Why don't start lateral? Because this is an area when you have a severe cervical foraminal stenosis, there's just 2 millimeters left or something. And if you start lateral, you might really sacrifice the root and you will not notice. You will notice at the end of the procedure when you come medial that you already have dissected the root. So you start medial, you expose the lateral border of the spinal canal, the dural vertebral sac, and then you see the exit of the root, then you go lateral. It's much easier this way. This is a typical result. I think it's nice to do this in 3 levels. You really have a nice exposure, far lateral on decompression of the nerve root, and it's easy, just drilling and then use the Carrison punch. I prefer personally to drill everything with a diamond burr and then the remaining bone flap to remove the Carrison punch, because as soon as you open the foramen, you have the risk, or you have some bleeding. Frequently, you always have some bleeding. If you don't have venous bleeding, probably you're not at the right position. You're not at the right target. Either you're still in the facade, or you're still. If you have to see the veins around the nerve root. If they are not there, probably it's not the nerve root you're dealing with. And this can be done with a very nice cosmetic results if you use one of these systems. So I just briefly show you our data. It's not this or only bony stenosis, and you see that we have most of them done with a medium-sized worksheet. Some small worksheet. There was no emergency stopping, no CSF leaks, no nerve root injury. I have to be honest, this is a series from Homburg where I work now. When we started this procedure, and I was not aware that there can be so many easy mistakes can be made that we had 2 or 3 cases in Mainz when I was in Mainz between 2008 and 2010. We had to interrupt the procedure because the venous bleeding was so tremendous that you could not control the intraoperative situation to achieve a sufficient nerve decompression. There was one bleeding surgery to post-op bleeding, and this is the results with the pain reduction. You see, it's a very, 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 very nice, very satisfactory procedure. Those patients, they have a clear radicular symptoms, bony stenosis in the cervical spine. They do very, very well, really. So it's almost 100% without previous surgery, 90% post-operative significant pain reduction with previous surgery. And you see paresis, there was a 100% recovery rate without previous surgery, 75 or 73% in patients with previous surgery. A little bit less successful patients who had already several procedures in the cervical, which is, I think, easy to understand. And the clinical success rate is 95%, the neck disability index very low. So it's, I think, it's a very, very successful procedure. So when we conclude, this is a nice tool. I think the posterior foraminectomy is should be applied whenever it's possible. It makes sense to do this. It's a good option. The smaller the approach is, and I think it's a very nice indication for an endoscopic approach. The smaller the approach is, the less post-op discomfort and pain these patients will have. And so I think it's a very good thing. So if you have any doubts, and someone left already, that's bad, because I have shown you a little bit of our experience. If you feel comfortable with endoscopy, you might think you swing from one tree to another like a young monkey. You're here. If you are not confident with an endoscopic procedure, then this might happen. and you recognize this man and you recognize this man. And then if you're not sure, you should not hesitate to call somebody either who knows how to do it or you switch to an open procedure. Thank you very much.